Okay, so here we are in chapter 17, part B. The first part of chapter 17 was a lot of anatomy and review of the heart and how it works, what chambers contract, fill with blood, and then eject blood. So please have a really good understanding of the heart and the anatomy of the heart and how everything works and the flow of blood through the heart, through the pulmonary circuit, through the systemic circuit, because you'll need to have a good understanding of that to kind of as we move forward. So the electrical events of the heart will depolarize. That means an electrical signal will be sent through it, and it will contract without nervous system stimulation, meaning the heart is able to establish its own heartbeat. Although rhythm can be altered by the autonomic nervous system, meaning the autonomic nervous system can increase the heart rate or decrease the heart rate. The coordinated heartbeat is a function of the presence of those gap junctions. The intrinsic cardiac conduction system is a network of non-contractile autorhythmic cells that will initiate and distribute these electrical impulses to coordinate the depolarization and contraction of the heart. And again, depolarization just means an opening of some ion channel for ions to rush in and to depolarize the cell membrane to cause an action potential to be passed through. Action potential is initiated by pacemaker cells. And, all right, oops, sorry about that. These cardiac pacemaker cells have an unstable resting membrane potential called the pacemaker potential or the pre-potential. There's three parts of an action potential in these cardiac cells. The pacemaker potential is when potassium channels are closed, but slow sodium channels will be open, causing the interior to become more positive. The depolarization kind of phase is when your calcium channels open, allowing a huge influx of calcium, leading to a rising phase of action potential. And the repolarization occurs when potassium channels open, allowing the exiting or efflux of potassium, and the cell goes back to becoming more negative again. So this just looks at like a typical kind of cardiac action potential cycle. We have the pacemaker potential, slow depolarization, a depolarization phase where we get that huge kind of positive upswing to an action potential peak. And then number three is a repolarization phase. And again, this pacemaker potential kind of phase in between action potential is just kind of a slow kind of depolarization phase leading up to those action potential peaks. The sequence of excitation, so we talk about this electrical signaling passing through these nodes and bundle branches throughout their cell. The cardiac pacemaker cell will pass impulses or electrical signals in the following order across the heart in about a quarter of a second. So this happens extremely fast. So these electrical signals will start in the sinoatrial node, and we'll see where that's located. They'll then be passed to the atrio or AV node into the atrioventricular bundle. And then from here, it will split into right and left bundle branches as it goes to the right and left ventricle. And then these bundle branches will split into these Purkinje fibers, which is a subendocardial connecting network that will bring the impulse to all of the myocardiac cells in the ventricles. So it starts in the SA node, this electrical signaling process. Your SA node is considered the pacemaker of the heart. It's located in the right atrial wall. It will depolarize faster than the rest of the myocardium. It generates this impulse of about 75 times a minute. That's called your sinus rhythm. And the impulse will spread across your atria and into the AV node. The AV node is inferior interatrial septum. So it's located kind of at the base of the right atrium in the wall that separates the two atrium. In the AV node, it will delay the impulse that's coming from the SA node for approximately a tenth of a second. This slowing of the impulse will allow the atria to contract and give time for the ventricles to fill with blood before they contract. So this slowing of the signal is extremely important in the AV node, just to allow the ventricles to completely fill with blood and for the atria to contract to kind of squeeze any blood out of the atria into the ventricles. Then from the AV node, this impulse goes into the AV bundle, also known as the bundle of His. It's in the superior interventricular wall, so in the wall that goes between the ventricles. It's the only electrical connection between the atria and the ventricles. And then from here, the AV bundle will separate into right and left bundle branches. So two pathways in your interventricular septum, which will carry impulses toward the apex of the heart. And then from that right and left bundle branch, the impulse will travel to this conducting network, which is maybe more commonly referred to as Purkinje fibers. And the Purkinje fibers will take this electrical impulse to all the myocardium sites or the myocardial cells in the ventricles. It will be more elaborate on the left side of the heart because the left side of the heart will have more myocytes or cardiac muscle cells because it's just a thicker wall to it. So those are the Purkinje fibers. You don't need to know how fast they go. This is 30 times a minute. I won't ask you guys to know that. I just want you to know the order. And this is probably a great just picture to study the order to remember it. So here's the SA node begins the electrical impulse. And then from there, it will travel to the AV node where the impulse will be slowed or paused to give time for the ventricles to fill up with blood following atrial contraction. And then the impulse will travel through the bundle of His into the right and left bundle branches, and then into the Purkinje fibers, which travel kind of into the walls of all of the cardiac sites in the ventricles. Some homeostatic imbalances, and you talk a little bit about these kind of in the workshop on the cardiac cycle. These are any defect in the intrinsic conduction system of the heart and any defect in this conduction system. So if cells are damaged, if there's a heart attack in the area that damages some of these cells, you could have an arrhythmia, which is any sort of irregular heart rhythm, where you have an uncoordinated atrial and ventricular contraction, which is not good. A fibrillation is a rapid, irregular contraction. You can have an atrial fibrillation or a ventricular fibrillation, depending on where it's located. The heart becomes useless for pumping blood because everything is erratic and totally irregular, causing circulation of blood to cease, and this will result usually in brain death. Treatment is a defibrillation will interrupt the chaotic twitching. So if you think of those, I'm blanking on the AED machines that are AED kind of areas that are located really throughout probably any building, public building now. That shock to the heart will try to defibrillate it and to put it back into normal, regular depolarizations again. So if you usually in any sort of, I think, basic CPR life support class, you learn how to use AEDs as well, which is important. It could save someone's life. The defective SA node, so if your SA node is defected, it may cause an ectopic focus, which is an abnormal pacemaker that takes over the pacing. If the AV node takes over, it sets a junctional rhythm at about 40 to 60 beats per minute. And extrasystole could occur, which is a premature contraction where the ectopic focus of the small region of the heart that triggers the impulse before the SA node causes a delay in the next impulse. So this is if your SA node is defected, some other part of the electrical conduction system kind of takes over and you could get an extra or premature contraction. It allows the heart, it gives longer time for the heart to fill, so the next contraction will be felt as a thud as larger volume of the blood is being pushed out, and it can be from excessive caffeine or nicotine. To reach the ventricles, an impulse must pass through the AV node. So many times we call heart blocks occurring if the AV node is defective. So if your AV node is defective, it may cause what we call a heart block, where the impulse, if it can't get through the AV node, it won't get through the ventricles. And if you don't get your electrical signal to your ventricles, your heart will not eject blood to your lungs or your circulatory system. Some impulses might get through to the ventricles, and we call that a partial block of the AV node, or no impulses could reach the ventricles, and that's a total block. Ventricles beat at their own intrinsic rate, and it's too slow to maintain adequate circulation. Treatment is usually an artificial pacemaker. So a pacemaker, they place the pacemaker usually kind of under the patient's clavicle, and then the pacemaker lead, which is the metal kind of cord, will travel through the part that is defective, if that is the AV node, to try to meet up with the other functioning parts of the electrical system. The heartbeat can be modified by your autonomic nervous system via cardiac centers in the medulla oblongata. So your cardio acceleratory center will send signals through your sympathetic trunk to increase both heart rate and force of contractions. And the cardio inhibitory center is via the parasympathetic system, which will decrease the heart rate. And that's through your vagus nerve, your cranial nerve. So this is just a look at autonomic innervation of the heart. Again, it's a good reminder to understand, again, that sympathetic cardiac nerves will increase heart rate and the force of contraction. Again, your sympathetic nervous system is the fight or flight response, and the vagus nerve of the parasympathetic will decrease heart rate. Electrocardiography is extremely important in clinical settings. I'm sure you guys will come across it. If not, you already have in your areas of work that you're doing right now. An electrocardiograph can detect electrical currents generated by the heart, and an electrocardiogram is a graphic recording of electrical activity over time. We call it an ECG or EKG in German. Cardio is a K. It's a composite of all the action potentials at a given time, not a tracing of a single action potential. So it will go through cardiac cycle after cardiac cycle, showing how well the heart is beating due to the electrical stimulus passing through it. To get an electrocardiogram, there are electrodes that are placed at various points on the body to measure voltage differences that are picked up on the skin surface that are coming from the heart. A 12-lead ECG is most typical. There's very particular places where they place these leads on the body, which I won't expect you guys to know, but I do want you to know the main features of an electrocardiogram. The P wave refers to the depolarization of the SA node and the atria. So the P wave will follow, so think of a P wave as an action potential that goes through your atria, and it will occur right before the atria contract. The QRS complex refers to when the ventricles will depolarize or get their action potential sent through, as well as the atria are repolarizing during the QRS complex. And then the T wave occurs when the ventricles repolarize. Then we have areas or segments between these main features. They are referred to as intervals or segments that will be, when I show you the picture of where just between these P waves, QRS complex and T waves. So this is just a look at where the skin electrodes are used to record an ECG. The round antenna near the patient's left shoulder reads his pacemaker data. So this patient has a pacemaker in him already, but he has several leads placed throughout the body to record his ECG. So this is the electrocardiogram, and this is just a great picture showing again how the electrical impulses will pass through the atria and ventricles, and showing what an ECG tracing will read and how it will look as if you're looking into in a clinical setting. So again, the P wave stands for atria depolarization. So you'll get this P wave action potential being recorded when the impulse travels through the atria. The QRS complex stands for ventricular depolarization, and then the T wave will stand for ventricular repolarization. Also labeled here is the PR interval. The PR interval stands for the amount of time it takes for the impulse to go from the atria to the ventricles. And many times in heart blocks, so if your AV node is blocked, this PR interval will be lengthened because there's some sort of blockage between the P wave in your atria and the ventricles being depolarized. Sometimes you might see a P wave and no QRS complex, and that would be a complete AV node block because you're getting the atria to depolarize in the P wave, but you don't see the QRS complex, so that means the ventricles aren't even getting an electrical impulse to it. So this ECG, I just think it's the coolest thing because you can tell so much about a person's heart and what could be wrong that will affect the rest of their body just with a recording of their ECG. This is another sequence kind of that shows all the events. It highlights the event in green and then describes what happens. It describes the PR interval here, the QRS complex, and then the ST segment. So this is maybe another good kind of slide to just study as you're learning this. So yeah, that's the ECG. Changes in patterns or timing of the ECG may reveal diseased or a damaged heart or problems with the heart's conduction system. So I'm just going to go back. So this along the x-axis, all these main events are measured in time, and each kind of box will have its own segment of time. So there's an appropriate or normal amount of time of a PR interval, and anything longer than that, they will measure that amount of time and be very specific. If it's even a millisecond off or too long, they would probably realize there's something wrong in that area of the heart. So problems can be detected. Enlarged R waves may indicate enlarged ventricles, for example. Elevated or a depressed ST segment will indicate a cardiac ischemia, which could lead to a myocardial infarction or a heart attack. More problems that can be detected. A prolonged QT interval reveals a repolarization abnormality that will increase the risk of ventricular arrhythmia. So a QT interval was the area between the QRS complex and the T wave, so between ventricular depolarization and repolarization. And if that interval is too long, it means there's some sort of abnormality in how your ventricles are trying to repolarize or get back to normal. So this is a great tracing. This is normal ECG trace. We call this sinus rhythm. So you can see here, it's easy to pick out the QRS complex first because that's kind of the tallest blip or of the depolarization. Right before that, we have a P wave, and then the one after that is the T wave. The T wave is usually a little bit higher than the P wave. And you can see how every box stands for, I believe it's 0.04 milliseconds. So you're able to kind of measure the amount of time between the P wave and QRS complex, and then there's your T wave. So this is normal sinus rhythm. This is junctional rhythm, showing that the SA node is non-functional. So what do you notice about this? So here, everything looks normal. You have a P, QRS, T. If we look at the junctional rhythm, you have your QRS complex and T wave, but there's no P wave. So P wave is absent, meaning that the SA node is probably not functioning. The AV node then picks up, doing what the SA node cannot, but it will pace the heart at 40 to 60 beats per minute, which is abnormal. So here's a junctional rhythm. Here's a second degree heart block, which has to do with your AV node failing to conduct some SA node impulses. So again, the impulses are getting from your SA node to the AV node, but at the AV node, there's something wrong with it, and it's blocking the impulses getting down to the ventricles. And you can see that here because you'll notice kind of a flat area where you don't have a QRS complex. So you have P, QRST, P, nothing, and then P, QRST, P, nothing. So you get this kind of 2-to-1 ratio of 2 P waves only generate about 1 QRS complex. So that's where the name second degree comes from. It's a second degree or 2-to-1 ratio of P waves to QRS complexes. So that's a second degree heart block. And again, the heart block is in the AV node. Does that make sense to everybody? Maybe you could put a thumbs up or a note in the chat. Do you have questions about any of that? Okay. All right, ventricular fibrillation then is when the electrical activity is completely disorganized, and you usually will just see this as a squiggly line. Obviously, this is probably the last thing you want to see if you hook a patient up to this. Action potentials are occurring randomly, so there's no coordination between your atria and ventricles contracting. And if you don't have coordination in your heart, your tissues aren't getting oxygen that they need. It will result in a chaotic, grossly abnormal. It's seen in acute heart attack and also after an electrical shock. So that's ventricular fibrillation. You might want to know what these look like. A good question on the test, I might put these into a test and have you guys tell me what's normal, what's a junctional rhythm, second degree heart block, ventricular fibrillation. So good to know what these look like, because I think it might be good to know as you go on. All right, the mechanical events of the heart. This takes us through the cardiac cycle, which is what the workshop is about. Systole is the period of heart contraction, and diastole is the period of heart relaxation. The cardiac cycle is blood flow through the heart during one complete heartbeat, and the cardiac cycle includes all of the events, the mechanical events, the electrical events, the pressure and blood volume. There's three main phases of the cardiac cycle. Sometimes they're broken apart into 5 phases, which is what you might learn about in the workshop. Following the left side, starting with total relaxation. So ventricular filling, this is mid to late diastole. This is when the pressure in the ventricles is low. And when the ventricles fill, about 80% of blood passively just flows into the ventricles from the atria. So your ventricles fill passively with blood, even without your atria contracting. When the atria do depolarize and contract, that will trigger atrial systole, which is what your P wave is when your atria depolarize. And that will cause your atria to contract, which pushes the remaining 20% of the blood into the ventricle. But for the most part, ventricular filling just occurs passively. Blood flows from your atria into the ventricles. Then atria depolarize, atria contract, pushing the rest of the blood into the ventricle. The amount of blood or the volume of blood in each ventricle at the end of ventricular diastole is called your end diastolic volume. You should know what that is. Depolarization will then spread to your ventricles. That's our QRS wave. The atria will finish contracting and will return to diastole while the ventricles begin systole, their contracting phase. Isovolumetric contraction. So this isovolumetric phase, whenever you see the word iso, that just means same. And this means that this will be contraction where the volume of blood remains the same. So this will be right before your ventricles actually eject the blood. They will contract first. And again, this happens in milliseconds. It happens extremely quickly. So your atria will relax during this isovolumetric contraction phase, and the ventricles begin to contract. When they begin to contract, it causes the ventricular pressure to rise or increase because there's a lot of blood in your ventricles and they're starting to squeeze, so that increases pressure in them. That increase in pressure causes the AV valves to slam shut. And that's the first heart sound you hear when a doctor listens to your heart in the stethoscope, the slamming or the closing of those AV valves. The isovolumetric contraction phase will be a split-second period when the ventricles are completely closed off, meaning all the valves are closed. The volume will remain constant, but the ventricles will continue to contract because we know eventually that their contraction will eject their blood to go either to your lungs or your body tissues. When the ventricular pressure gets too great or exceeds pressure in the large arteries, your semilunar valves will be forced open. And remember, your semilunar valves are at the opening to the pulmonary trunk and the aorta. The pressure in the aorta reaches about 120 millimeters of mercury. That number should be familiar because that's the number, if you've taken somebody's blood pressure, that you want their highest kind of top number to be and not more than that. So isovolumetric relaxation, then this is the early diastole phase. This follows ventricular repolarization. So after the ventricles have then ejected their blood when the semilunar valves open, we get an end systolic volume, which is the volume of blood remaining in each ventricle after systole. So there's always a little blood left in your heart after your ventricles eject. The ventricular pressure will drop back down because all the blood has left. So pressure drops, causing a backflow of blood from the aorta and the pulmonary trunk that will slam the semilunar valves shut. And when those semilunar valves slam shut, that's the second heart sound you hear. So the lub-dub, lub-dub, lub-dub sound you hear in a stethoscope, the lub is the closing of your atrioventricular valves, and the dub sound is the closing of your semilunar valves. The ventricles will be completely closed chambers again momentarily, and this is referred to as the isovolumetric relaxation phase. The closure of the aortic valve will raise an aortic pressure as backflow, which will rebound off the closed valve cusps, and this is referred to as a dicrotic notch. The atria will continue to fill during ventricular systole. Remember, there's no valves that go at the entrance of blood into the atria, so they're continuing to fill during this time. And when atrial pressure exceeds ventricular pressure, your AV valves will open again and the cycle begins again. But when those AV valves are closed, your atria have continued to fill with blood this whole time. So when they open, that's where we get 80% of the blood just will passively flow back into your ventricles. The heart beats around 75 times per minute. So what I just described, this cardiac cycle phase, happens 75 times a minute. So it's probably happened 300 times since I started talking about this. The cardiac cycle lasts about 0.8 seconds. This gives you how long atrial and ventricular systole last. I probably won't know, you don't need to know that. You should know what the normal heartbeat around 75 times per minute is. So this takes you through the cardiac cycle, those three main phases we talked about. Yeah, if you can, I don't know if there's still cardiac cycle workshops, but if you can get to one, I don't know, hopefully it's helpful. So this takes you through the phases of the cardiac cycle, showing you, and again, the cardiac cycle includes all of the mechanical and electrical events, including pressure changes and volume changes. So there's a lot going on in this graph. If you start at the bottom, it describes the heart sounds, and you'll see here the lub, that first heart sound is caused by AV valve closing. So then if you work your way up, you can see kind of how the pressure changes and volume changes will work around that AV valve closing. Then the dub sound is the second heart sound, is caused by the semilunar valve closing. And as you work your way up, you can read through the events that will surround that semilunar valve closing. So that's the cardiac cycle. This takes you through probably a better kind of description with pictures at the bottom, showing kind of the same events of the cardiac cycle, but how blood is flowing from the atria to the ventricles during atrial contraction. The isovolumetric contraction phase is again when all the valves are closed, but pressure builds up. So you'll see pressure at the highest as well as blood volume the highest in the ventricles as you work your way up through these graphs. And then you see the ventricular ejection phase, where pressure will greatly decrease and ventricular volume will decrease as volume is ejected. And then you'll see the isovolumetric relaxation phase, where all valves are closed, but everything is relaxing and going back to normal. So your heart sounds, we talked a little bit about these. The first sound is the closing of your AV valves. The second sound is the closing of your semilunar valves. And the pause between the lub-dub, lub-dub, lub-dub sound is just when your heart is relaxing. Mitral valve closes slightly before the tricuspid valve. So again, those are mitral and tricuspid are your AV valves. And the aortic closes slightly before your pulmonary valve. And the differences allow auscultation of each valve. That means listening when the stethoscope is placed in 4 different regions. So doctors can get really good at determining if they're listening for the tricuspid, the mitral, the aortic, or the pulmonary. So this is where the doctor will place their stethoscope and where the sounds of the individual valves are heard most clearly. So this is why you'll notice your doctor should be placing their stethoscope in 4 different spots, kind of around the sternum. And these 4 different spots will show you where they can hear these valves the best. So why do your doctors listen to your valves? They're listening for any abnormal heart sound, and an abnormal heart sound is called a heart murmur, and it's heard when blood hits some sort of obstruction. It usually indicates a valve problem, such as an incompetent valve where it is failing to close completely, allowing backflow of blood either back into the ventricles or back into the atria. It will cause a swishing sound as blood is being regurgitated backward. And this swishing sound sounds just like that. The doctors will hear a swishing sound in their stethoscope. So that's an incompetent valve. A stenotic or stenotic valve are when the valves fail to open completely, which will restrict the blood flow through the valve. And this causes more of a high-pitched sound or a clicking sound as blood is being forced through a narrow valve. So again, a simple stethoscope can give the doctor a really good understanding of what the heart is doing. That and an ECG, it's amazing what two simple things can show doctors, ECGs and stethoscopes. The cardiac output is the amount of blood pumped out by each ventricle in 1 minute. And it's important to understand cardiac output because this is a number of to assess the ability of the heart to pump blood. The cardiac output is equal to the heart rate times the stroke volume. And the stroke volume is just the volume of blood pumped out by one ventricle with each beat. And it will correlate with the force of contraction. So at rest, if your heart rate is normally about 75 beats per minute and the stroke volume is about 70 milliliters per beat, so that's about 70 milliliters of blood pumped out of one ventricle with each beat, we get at rest, your cardiac output is normally about 5.25 liters per minute. I want you guys to just know how to calculate cardiac output. So cardiac output is equal to heart rate times stroke volume. If you can just remember that equation, because we'll learn about how cardiac output is then changed or regulated with different things that your body could be going through. The maximal cardiac output is 4 to 5 times resting cardiac output in a non-athletic person, and the maximal cardiac output could reach 35 liters per minute in trained athletes. Can you believe that? So normal is about 5, and in a trained athlete, it can be as much as 35 liters. That's 30 liters more. So work out your heart. It's so important to exercise. Just your heart is a muscle and you want to exercise that too. The cardiac reserve is the difference between resting and maximal cardiac output. Cardiac output changes it can increase or decrease if either or both the stroke volume or the heart rate is changed. So the cardiac output is affected by factors leading to the regulation of stroke volume and the regulation of heart rate, because cardiac output, again, is stroke volume times your heart rate. So anything that affects stroke volume or heart rate will change cardiac output. And this is just a good kind of graph, kind of exchanging what could affect cardiac output by separating out what will affect stroke volume and what will affect heart rate. And again, just something good to understand. You don't have to understand if this is causing you to get really confused. Just look here up at the pink boxes. Exercise by increasing sympathetic activity, increasing skeletal muscle and respiratory pumps will increase the ability for your veins to return blood back to the heart faster. So that'll increase your stroke volume or increase the amount of blood being ejected. Ventricular filling time, blood-borne epinephrine, excess calcium and thyroxine. So these are all, think of your adrenaline response. That'll also increase stroke volume. Things that'll increase heart rate are changes in your autonomic nervous system. So your fight or flight response, exercise, anxiety, a decrease in blood pressure. Sympathetic activity will increase the heart rate, and parasympathetic activity will decrease the heart rate. So that's how these different things will affect your cardiac output. A little bit more about regulating stroke volume. I probably won't ask you too many specifics about this, but I'm just going to talk you through it so at least you've heard of this before. There's 3 main factors that affect stroke volume: your preload, your contractility, and your afterload. The preload is the degree of stretch of the heart muscle. It's the degree to which your cardiac muscles are stretched just before they contract. So a change in this preload stretch will cause changes in the stroke volume. It will affect the end diastolic volume. Your cardiac muscle exhibits a length tension relationship. At rest, your cardiac muscle cells will be shorter than optimal length, which leads to a dramatic increase in that contractile force. So that's what preload is, just stretching of cardiac muscle. Contractility is the contractile strength at given muscle length. So increased contractility will lower the end systolic volume. This is caused by sympathetic epinephrine releasing, which will stimulate increased calcium influx. Positive and negative inotropic agents you don't need to know. So contractility is just the contractile strength of the muscle. And I won't have you guys learn how norepinephrine increases heart contractility. It uses a second messenger, cyclic AMP, but you should know just that norepinephrine does increase heart contraction. That's your adrenaline. And then the afterload and it also regulates stroke volume. The afterload is just the back pressure exerted by arterial blood. So it's the pressure that your ventricles must overcome to eject the blood. If this is back pressure that's from your arterial blood, it's pushing on the semilunar valves. It's a major pressure. Hypertension will increase the afterload, which will result in increased end systolic volume and reduced stroke volume. So hypertension, this pressure put on the ventricles from the arteries will increase the afterload, which will reduce the stroke volume. So that's afterload, it's just back pressure. So again, this is kind of the same chart showed before, but just going over again factors involved in determining your cardiac output. More regulation of heart rate, chemical regulation of heart rate is from hormones. Epinephrine increases heart rate and contractility. Thyroxine increases heart rate. It will enhance the effects of norepinephrine and epinephrine. This is kind of your adrenaline response. Ion concentrations must be maintained for normal heart function, and an abnormal ion imbalance is very dangerous to the heart. And these ions, again, are the ions that are moving into and out of heart cells to help with depolarization. So you want your ion concentrations to be normal. Hypocalcemia, so an decreased calcium levels will depress the heart. Hypercalcemia, so increased calcium will increase the heart rate and contractility. Then we get the same with hyper and hypokalemia, which is your potassium ions. They'll also could affect the heartbeat, heart activity, which could lead to heart block, cardiac arrest, or an arrhythmia. So you want your ion levels of calcium and potassium to be normal. Other factors that influence heart rate, your age. Fetuses, babies in the wombs have extremely fast heart rates. This will decline as they get older. Gender, females generally have a higher, faster heart rate than males. Exercise increases heart rate. However, if you have a trained athlete, they can also have a slow heart rate at rest. Body temperature, the heart rate will increase with increased body temperature. I do want you to know what tachycardia and bradycardia is. Tachycardia is an abnormally fast heart rate, anything over 100 beats per minute. If it's persistent and doesn't go away, that could lead to fibrillation. And bradycardia is an abnormally slow heart rate, anything less than 60 beats per minute. If it's too slow, it could result in inadequate blood circulation in non-athletes, but it could be a desirable result of endurance training. So many athletes have bradycardia, a slower heart rate, because their heart is able to function at rest at just a much slower rate because it can beat out so much more blood with each heartbeat. Congestive heart failure is a progressive condition. The cardiac output is so low that the blood circulation is inadequate to meet tissue needs. It will reflect weakened myocardium, often caused by coronary atherosclerosis, which is, again, that fat buildup, clogging your arteries, which is impairing oxygen delivery to your cardiac cells. Heart becomes hypoxic, so decreased oxygen, so it contracts inefficiently. Persistent high blood pressure can be a cause of congestive heart failure. Multiple MIs or heart attacks, the heart becomes weaker as contractile cells are replaced with scar tissue. So when your contractile cells become damaged from a heart attack, they're not replaced with more contractile cells, they're just replaced with scar tissue. Dilated cardiomyopathy is when your ventricles will stretch and become flabby and the myocardium deteriorates. This could be due from a drug toxicity or chronic inflammation. Congestive heart failure can affect either the right or left side, and depending on what side of the heart is affected, that will cause pulmonary congestion, blood backs up in your lungs, or peripheral congestion, blood pooling in your body organs causing edema or swelling in parts of the body. Failure of either side will ultimately weaken the other side because it will lead to decompensation, a seriously weakened heart, where the other side of the heart has to compensate for the side of the heart that's not working. Treatment is to remove the fluid caused from that blood pooling, the edema, and drugs to reduce the afterload, which is the pressure buildup, usually due to a blockage of your arteries and increased contractility. So I will stop the recording there.